Okay, now we're gonna talk about pulmonology and musculoskeletal. Okay, so if you are a 48-year-old man, when your oxygen saturation is 94 on room air when lying on your right side and drops to 84 when lying on your left side, what is the cause of that? This is due to increased physiologic shunting, period. Okay, so if you are a 56-year-old woman who came to the physician with a 1 day of hemoptysis and there is mild cough with scant sputum production for the previous 4 months with weight loss, and on chest x-ray you found 5 cm irregular nodule on the peripheral right upper lung field. What it could be? This is most likely adenocarcinoma of the lung, period. Okay, so if you are a 69-year-old man with lower extremity edema, shortness of breath, on lung exam shows decreased breath sound and 18 cm and ascites present, chest x-ray is enlarged and central pulmonary arteries without evidence of vascular congestion. So what is could be? So when you have the liver enlarged, ascites, decreased breath sounds, this is most likely what's called cor pulmonale. So what is the characteristic of cor pulmonale? It's caused by COPD, is the most common, interstitial lung disease, pulmonary vascular disease like a PE, obstructive sleep apnea, dyspnea on exertion, fatigue, exertional syncope, exertional angina, peripheral edema and increased JVP, loud S2, right-sided heave, pulsatile liver from congestion, tricuspid regurg murmur. On imaging, EKG, you have partial or complete right bundle branch block, right axis deviation, right ventricular hypertrophy, and right atrial enlargement. On echo, you have pulmonary hypertension, dilated right ventricle, tricuspid regurg. Those are the findings. On the right heart, catheterization is the gold standard for diagnosis. Will show right ventricular obstruction, pulmonary hypertension with no left heart disease. So that's how you diagnose these types of conditions. Okay, period. Okay, so if you are a 40-year-old male who presents with shortness of breath, cough, and hemoptysis for the past 2 days, your medical history is significant for non-healing leg ulcer and chronic purulent nasal discharge. Okay, and you found 2 by 3 cm ulcer with rolled undermined borders is noted on the right lower leg. What could be causing your issue? This is most likely granulomatosis with polyangiitis, vaginal granulomatosis. They have hemoptysis, non-healing leg ulcer, and purulent nasal discharge. That's how they present it. Period. So when you are a 63-year-old male who have loss of weight and you're 40-pack year smoker, and when I examine you, you expire in a pursed lips and the finger shows prominent clubbing. What could be causing this? This is most likely a malignancy. So the conditions most likely associated with digital clubbing is intrathoracic neoplasm, for example, bronchogenic carcinoma, metastatic cancer, malignant mesothelioma, lymphoma, or it could be intrathoracic suppurative disease, for example, lung abscess, empyema, cystic fibrosis, chronic cavitary infection, fungal mycobacterial, and lung infection, for example, idiopathic pulmonary fibrosis, asbestosis, pulmonary arteriovenous malformation, or cyanotic congenital heart disease. All of those can cause digital clubbing, period. Okay, so if you are a 32-year-old female with 3 episodes of pneumonia, severe sinusitis 1 year ago, chest x-ray shows right lower lobe infiltrate, crackle, you had some episodes of diarrhea, bloody diarrhea. What could be causing this? So you have recurrent infections, GI and respiratory. This is immunodeficiency, so you do quantitative measurement of serum IgG level. That's how you work up this condition. Okay, so if you are a 56-year-old male with hemoptysis for the last 2 weeks and you are a smoker, 45-pack year smoking history, your sodium is 124, chest x-ray shows 3 cm right-sided parahilar nodule. So what's the treatment, best treatment for that? It's fluid restriction. That's the best treatment. So, okay, so if you are an 80-year-old female with foul-smelling productive cough and you have dementia and right lower lobe pneumonia, what causing pneumonia? It's impaired epiglottic reflex, period. So if you are a 44-year-old Asian immigrant, you have persistent cough, dyspnea on exertion for about 3 months, and you have progressively shortness of breath and unable to lie flat. When I do chest x-ray, I found enlarged cardiac saluting with vascular congestion, and the left main stem bronchus appear to be elevated. Okay, and the EKG shows irregular rhythm. What could be causing this? This is most likely rheumatic heart disease, period. Okay, so if you are a 35-year-old male who present with recurrent sinusitis, on chest x-ray, I found multiple nodular densities bilaterally. Creatinine is 2.7. Wow, sinusitis, densities in the lung, creatinine increase. What's causing this? Or what's best next step? The best next step, we do serum antineutrophilic cytoplasmic antibody, because this could be vaginal granulomatosis polyangiitis, period. Okay, so if you're a 61-year-old guy with exertional dyspnea, decreased exercise tolerance, smoker, okay, and you have you see all the ribs on chest x-ray, what's causing that? This abnormal diaphragmatic contour, most likely due to increased work of breathing because of the air trapping and COPD. That's what's causing your issue. Okay, now if you are a 30-year-old African American female who presented with uveitis and shortness of breath, when I do chest x-ray, I found diffuse interstitial infiltrate. So what's your condition? Excellent, this is sarcoidosis, period. So what are the features of sarcoidosis? What are the features, of asbestosis? Asbestosis, presentation, you have history of prolonged asbestos exposure, shipyard, mining, construction worker, pipe fitters, and symptoms developed more than 20 years after initial exposure. And they have progressive symptoms, dyspnea over months, bibasilar and inspiratory fine crackles and clubbing. Evaluation, history, and clinical finding. They have pleural plaques on chest imaging, virtually pathognomonic, and interstitial fibrosis on imaging, or history of pulmonary function tests with restrictive pattern. Okay, that's how you diagnose it. And on chest x-ray, you found pleural plaques. On imaging, you have interstitial fibrosis, and exclude other causes. That's how you diagnose. Okay, so if you are a 38-year-old woman with a blood-tinged sputum, and I found scattered bilateral wheezes and bronchi that clear with coughing are heard on chest auscultation. Chest x-ray shows a clear lung field, and you just had a sore throat, nasal congestion 10 days ago. So what's causing your bloody sputum right now? This is most likely called acute bronchitis. So the management for that is very simple, just supportive. Okay, so if you are a 42-year-old man who complain of a daytime sleepiness, okay, and you fall asleep during meeting, watching TV, okay, your BMI is 31.3 and ABG is normal. So what's causing this problem? Your BMI high and daytime sleepiness, and you're refreshed after daytime naps. So what is causing that? This is obstructive sleep apnea. So you gotta differentiate between obesity hypoventilation syndrome and obstructive sleep apnea. Obesity hypoventilation syndrome is more severe feature of OSA. The PaO2 is much lower and the BMI higher. That's how we differentiate that. Okay. So now let's see. Now when you are another case, if you are a 55-year-old male who have the FEV1 is 67%, but after bronchodilator, I found you to have 82%. So what's causing this your symptom? It's most likely asthma. That's what's causing yours. Okay, so if you are a 52-year-old male who presents with a 4-week of non-productive cough, nighttime sweating, and you had a hepatitis C, when I do chest x-ray, I found right upper lobe cavity with surrounding infiltrate. So what's most important epidemiologic clue to this condition, cavitary disease? It's most likely immigration from endemic area, because this is TB, period. Okay, so if you are an obese 56-year-old female who have hoarseness, cough at night, mostly after food, how do you treat that? This you give esomeprazole, because this is GERD symptoms. Okay, now if you are a 45-year-old man who have bilateral hand pain that's severe in your wrist, with your exam I found bilateral wrist tenderness, thickening of the distal fingers, and convex nail beds. You're a smoker for the past 25 years. What should I do right now? You have hypertrophic obstructive cardiomyopathy, most likely lung cancer, so I'll just order a chest x-ray. Period. Okay, so if you are a 54-year-old man from Southeast Asia, you came to the clinic with a generalized malaise and cough, and I also found you also found intermittent hemoptysis for the past 3 months. Okay, when I examined him, I found rhynchi. When I examined you, I found rhynchi on the right middle lung field. Okay, and the CT shows a scan of the chest shows a fungal ball. What's causing that? This is aspergillus. So pulmonary aspergillosis risk factors is when you have asthma, COPD, TB, sarcoidosis, malignancy, and immunocompromised. How does that present? Pleuritic chest pain, dyspnea, cough, hemoptysis. How do you confirm it on labs? You have positive aspergillus IgG plus radiographic evidence of a single, multiple nodules, cavities, plus minus fungal ball, consolidation, and peribronchial infiltrate. That's how you diagnose it. How do you treat it? If it's aspergilloma, I'll do surgical excision. If it's an invasive aspergillosis, I do voriconazole or caspofungin. Period. Okay, so if you are a 60-year-old man who complain of cough, dyspnea on exertion, the cough for over 2 years and getting worse. You are a 60-pack-year smoker. Wow, you work in the shipyard. When I do pulmonary function test, I found the FEV1 is 67%. FVC is 95%. Wow, the FEV1 over FVC is 65. Okay, carbon monoxide diffusion is 100%. So this rules out COPD. So what could be causing this? This is chronic bronchitis. So this is how do you interpret the pulmonary reading. This is very important, vital component. So if you find an obstructive pattern, the FEV1 over FVC less than 70% of predicted, then you look at the DLCO. If it's so now FEV1, you look at FEV1 and FVC. FEV1 over FVC, if it's less than 70%, then you look at the DLCO. If it's decreased, this is emphysema. If it's normal, it's chronic bronchitis or asthma. If it's increased, it could be asthma. This is an obstructive pattern. But if you find restrictive pattern on FEV1, FVC more than 70%, and then you look at the DLCO, if you found it low, then this is most likely interstitial lung disease, sarcoidosis, asbestosis, or heart failure. But if you find it normal, this is most likely musculoskeletal deformity, neuromuscular disease. That's what's causing it. But if it's increased, then most likely in morbid obesity, increased DLCO. But if you have normal spirometry but low DLCO, it's most likely anemia, pulmonary embolism, pulmonary hypertension. But if increased DLCO with normal spirometry, then most likely pulmonary hemorrhage or polycythemia. That's how you differential diagnosis of carbon monoxide diffusion capacity of the lung. Very important concept. Period. Okay, so if you are a 67-year-old male who presents with a 1 month history of dyspnea on exertion, chest pain, but without hemoptysis or night sweats, the pleural fluid shows a total protein of 5.2, cytologic examination shows 600 white blood cell count, including 67% lymphocyte, and serum total protein is 6. So what's causing this pleural fluid analysis according to light criteria? So this is most likely increased capillary permeability because you have a lot of white PC in the pleural fluid and a lot of protein. So if it was transitive, then it's different. The protein will be lower and white blood cells will be much lower. So when you are a 33-year-old man with no complaint, you spend your entire life in suburban Mississippi, but I did chest x-ray. I found 1.5 nodule in the right mid-lung field. Okay, so what could be causing that? This is histoplasmosis. It's asymptomatic and immunocompetent. So if you this is very interesting condition. If you are a 65-year-old man with palpitation, headache, insomnia, vomiting, okay, after I've given you ciprofloxacin and thiophanate, and when I did echo, I found EKG, I found multifocal atrial tachycardia with a single ventricular premature beat. What could be causing this, or what should be next step? So I will measure serum thiophanate level because could be thiophanate toxicity. Period. Now, if you are a 36-year-old man with a 4-month history of coughing, and that's productive of white sputum, worsen at night. Okay, you take the dihydrophenamine, what's going on? Diphenhydramine, and this makes you sleepy and doesn't improve the cough. I do examine your heart. I found split second heart sound with inspiration, but no murmur, which is okay. So what's next step? So we'll just do pulmonary function test. That's the best thing. And see what's going on. Could be asthma. Okay, so if you are a 34-year-old female with a vague chest pain and recent upper respiratory tract infection, when I do chest x-ray, I found enlarged mediastinum, and helical CT shows mass in the middle mediastinum. What's causing this? Most likely bronchogenic cyst, mass in the middle mediastinum. But thymoma, it's in the anterior mediastinum. Retrosternothyroid, it's in the posterior mediastinum. Okay, esophageal myoma, I think it's a posterior mediastinum too. Other stuff that can cause middle mediastinum mass is pericardial cyst, bronchogenic cyst, lymphoma, tracheal tumor, aortic aneurysm. Those cause middle. But the posterior mediastinum mass is a lymphoma, meningocele, enteric cyst, esophageal tumor, diaphragmatic hernia, aortic aneurysm. Okay, those are the things. Okay, so if you are a 34-year-old male who presented with a 5-year history of bronchial asthma that on average occurs 2 times per week during the day, but in the last couple of weeks the asthma symptom wake you up from sleep 3 to 4 times per month, that's annoying. You don't want that, right? Like 2 times per week and 3 times per month. That's annoying. So the best thing to do is just give you inhaled steroid. I'll add it to albuterol. Okay, so if it's less than twice a week, less than 2 times a month, this is just albuterol. But if it's mild persistent, which is more than 3-4 times a month and more than twice a week, like this patient, give him inhaled steroid. But if it's moderate persistent, like more than 4 times a month at night, or in the day, every day you have it. That's an annoying when it becomes starting every day, so you give them long-acting beta bronchodilator. But if it's severe every night, every day, all day, less than 60%, then I'll just give you oral steroid. Because this is dangerous. This man is dangerous. Okay. So if you are a 54 male with a chronic cough and recent bloody sputum, on calcium I found it 12.9, and chest X-ray shows hilar mass in the left lung. Biopsy of the hilar mass will reveal what? What do you think? Will reveal squamous cell carcinoma of the lung. That's the difference. Period. Okay, so if you are a 53-year-old male with 2 episodes of hemoptysis over the past week, and you had a 2-year history of morning cough predictive of 1 tablespoon, and you smoked for 30 years, and you tried to cut down recently and you couldn't, but now you have 2 episodes of hemoptysis and chronic cough. What's causing this? Is chronic bronchitis, and you're a smoker. So the common cause of hemoptysis could be pulmonary, like bronchitis, pulmonary embolism, bronchiectasis, lung cancer, or could be cardiac, such as mitral stenosis, TB, lung abscess, could be coagulopathy, AV malformation, vaginal granulomatosis, Goodpasture syndrome, SLE, vasculitis. Any of those can cause hemoptysis. Okay, so if you are a 45-year-old female with a PaO2 of a 60 and PaCO2 of a 69, so what's causing this? This is most likely nocturnal hypoventilation. Okay, so if you are a 48-year-old male who have a persistent cough that's been treated with several courses of antibiotic with intermittent resolution of the symptoms, okay, your serum albumin is 2.9, creatinine 1.1. Okay, what are the complications of this bronchiectasis? So bronchiectasis bullae can cause hemoptysis. Okay, if you are a 34-year-old woman with a sudden chest pain, taking OCP, mild fever, and wedge infarct on CT, most likely pulmonary embolism. Period. Okay, so if you are a 72-year-old male, when I do the right atrial pressure, I found it 18. This is high. And pulmonary artery pressure is 43, high too. Pulmonary capillary wedge pressure is normal, 9. What's causing this? It's pulmonary embolism, period. Because the heart is fine, but the arteries is causing the problem. Okay, if you are a 65-year-old male who have a 2-year of persistent cough, and you cough white sputum almost every morning on awakening, and you cough throughout the day, okay, so what's causing this? And pulmonary function tests reveal vital capacity that is 65% of predictive. What's causing that? It's most likely air trapping during expiration. Okay, so if you are a 50-year-old male who have a cough and right shoulder pain with a drooping of the eyelid, ESR 55, what should I do? Now I should do chest X-ray because it could be pancreas tumor. That is present with a weakness, C8T1, paresthesia and 5th digit, medial arm and forearm, supraclavicular lymph node enlargement, weight loss, Horner syndrome, shoulder pain, can cause all of that. Okay, so if you are a 45-year-old white male with a daytime somnolence, fatigability, and morning headache, your BMI is 31. So how can I treat that? What's going on? Daytime somnolence, just reduce weight, you will be fine. So if you are a 23-year-old woman who was stung by a B. At a park. When I examine you, I found audible wheezing, skin is warm to touch, heart blood pressure is 80/50, and pulse is 100. What should I do? Now I am epinephrine. Period. That's it. It's anaphylaxis. It's a shock. So now another question. If you are a 50-year-old obese male with daytime somnolence and a blood pressure of 160/100, what should I do? I should do nocturnal polysomnography. That's what I'm period. If you are a 55, this is what we're talking, is the first part of pulmonary system. That's what I'm talking about. I'm gonna do it in 2 parts, okay? Okay, so if you're a 55-year-old guy with a recurrent pneumonia, what should I do? Do a CT scan. Because the causes of recurrent pneumonia, if it's involved same region of the lung, it could be anatomic, like neoplasm, adenopathy, vascular anomaly, bronchial compression, or it could be intrinsic bronchial obstruction. For example, bronchiectasis, retained foreign body, bronchial stenosis. It could be recurrent aspiration, like seizure, ethanol, or drug. It could be GERD, can cause that. Dysphagia, achalasia can cause that. But if it's involving different regions of the lung, it could be pulmonary disease, cystic fibrosis, and motile cilia. Or it could be non-infectious vasculitis, bronchogenic obliteran, organizing pneumonia, immunodeficiency, HIV, leukemia, decreased immunoglobulin. So those are the causes of recurrent pneumonia. Okay, so if you are a 65-year-old male with a productive cough and a fever, when I examine you, I found decreased breath sound and crackles on the left lower lobe of the lung. What should I do now? Do chest x-ray. Period. And that's the end of the first part of the pulmonary system. Period. See you next time. See you in the second part.